Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. In this presentation, we are going to be discussing nephrotic syndrome pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, nephrotic syndrome. This is a commonly tested entity. Guaranteed you will see it. Nephrotic syndrome is characterized by proteinuria and glomerular disorders, leading to hypoalbuminemia and pitting edema. To the right here, we can see a collection receptacle of urine, right? Because a urine analysis will be utilized to detect the high levels of proteins and the occasional microscopic hematuria that may be present. Now, with nephrotic syndromes, there's a handful of diseases that you must be aware of. Those include minimal change disease, right, with its minimal changes, focal segmental glomerulosclerosis, FSGS, with its focal lesions, membranous nephropathy, Membranoproliferative glomerulonephritis, diabetes mellitus, of course, with the Kimmel-Still-Wilstein bodies, something like that, as well as systemic amyloidosis. Complications of nephrotic syndrome includes hypogammaglobulinemia, which increases the risk of infection, right? If you don't have the immunoglobulins around to partake in the inflammatory response. Could also have hypercoagulable state due to the loss of antithrombin 1, hyperlipidemia, as well as hypercholesterolemia. Here's a patient with nephrotic syndrome. Notice how swollen their face appears. And here's a microscopic image from a kidney biopsy from a patient with diabetic glomerulosclerosis who presented with nephrotic syndrome. And for the future radiologists out there, here is a hyperechoic kidney without demarcation of the cortex and medulla, which can be seen with nephrotic syndrome. And this is something that you must be familiar with. It's the histopathology from a patient with glomerulosclerosis and nephrotic syndrome, right? This person has diabetic glomerulonephritis. The PAM stain highlights the pathology in this image. And here's another image that you should be aware of. We're seeing that it is possible to see a glomerulus in the center of an image. Now, that is a key microscopic finding that will often show up in cases and be a dead giveaway for what you're actually looking at. So that can help you narrow your differentials in certain settings. And as we know, an ultrasound of the kidney can highlight certain features of nephrotic syndrome, right? And this is a microscopy that you will definitely be asked about. So let's cut into this. We have A, B, C, and D. In A, we can see FSGS. In B, we can see segmental glomerulosclerosis. Note the capillary bundle and the segmental collapse. On C, we can see hepatitis B, core antigen, immunostain. And with D, we can actually see immunofluorescence showing the glomerulus and the mesangial area along the grain. Isn't that fantastic? In regards to nephrotic syndrome, This is for the MD, PhDs out there. It's unlikely to be in the test setting, but if you want to satisfy your curiosity, note that the BASP1 expression takes place in some tubular cells in patients with nephrotic syndrome and can actually be stained immunohistochemically. Now let's talk about an important condition to be aware of called minimal change disease. This will definitely show up for sure. Minimal change disease is the most prevalent cause of nephrotic syndrome in children, right? You will definitely see this. Minimal change disease, most common cause of nephrotic syndrome in children. Minimum change disease is typically idiopathic, no known cause, but it can be linked to Hodgkin lymphoma. The kidney histology looks normal in minimal change disease, hence the name, minimal change disease. However, electron microscopy can be utilized to visualize the pathology that is associated with this condition, which is podocyte foot effacement. Electron microscopy of minimal change disease shows podocyte foot effacement. Selective proteinuria may be present due to the loss of albumin, but not immunoglobulin. And how do you treat minimal change disease? Fortunately, we can use steroids. Minimal change disease is treated with steroids. Here we have a patient with minimal change disease. This is what they might look like clinically, right? Because they're losing the albumin, leading to edema. Here we could see periorbital edema in a patient with minimal change disease. Would you treat them with steroids? Probably. For the most part, yes, and definitely in a clinical test scenario. And here is some histology from a patient with glomerular deposits. Note that in patients with minimal change disease, there's very weak expression of PLA2R on the glomerular podocytes. Now let's talk about another commonly tested entity called focal segmental glomerulosclerosis, or FSGS for short. Now, focal segmental glomerulosclerosis is the most common cause of nephrotic syndrome. If you take a look at the H&E image, you can see a high magnification micrograph of FSGS. And this is a pass stain. Particular ethnicities are at risk of focal segmental glomerulosclerosis, which include Hispanics and patients of African-American descent. FSGS can also be linked to HIV infection, heroin use, and sickle cell disease. Histology of FSGS typically shows segmental and focal fibrosis and sclerosis, as we can see here to this image in the right. There are no immune complex deposits associated with focal segmental glomerulosclerosis. Treatment of FSGS is steroids. And if focal segmental glomerulosclerosis does not respond to the steroid treatment, that portends to a worse diagnosis. Chronic renal failure is a complication of FSGS. Now here to the right, we have a renal biopsy showing the collapsing variant of FSGS. And these arrows here, they indicate a widened and effaced podocyte foot process. B is the electron microscopy from that same glomeruli. Now here's another entity that you must know about. Membranous nephropathy. Membranous nephropathy is the most common cause of nephrotic syndrome in Caucasian adults, right? Membranous nephropathy is the most common cause of nephrotic syndrome in Caucasian adults. And I reiterate that because on questions, they like to get at the nuances between the commonalities or what's more prevalent. For instance, FSGS and minimal change disease and membranous nephropathy all have certain prevalences and incidences that you must know. So make sure you know the numbers. Now, membranous nephropathy is normally idiopathic. Known causes of membranous nephropathy include hepatitis B, hepatitis C, cancer, SLE, NSAIDs, and penicillamine. The histology of membranous nephropathy typically shows glomerular basement membrane thickening. You must remember that. The histology of membranous nephropathy shows glomerular basement membrane thickening. That will show up. A periodic acid shift stain may highlight the thickened basement membrane dark pink. An electron microscopy of membranous nephropathy shows subepithelial deposits with spike and dome appearance. Buzzword there, spike and dome appearance due to immune complex deposition. Chronic renal failure may develop as a complication of membranous nephropathy. And here we have images from the microscopic level showing IgG4 related membranous glomerulopathy. In A, we utilized a PAS stain. B, you can see IgG4 IHC confirming the several IgG4 expressing plasma cells that were present in the glomerulus. That's why in the glomerulus it has this dark brown coloration. Plasma cells. And C, showing the electron microscopy that demonstrates those classical subepithelial electron dense deposits consistent with membranous glomerulopathy. And here we have something for the MD PhDs out there, unlikely to be tested, but for curiosity's sake, IHC analysis for thrombospondin type 1 domain containing 7A and M-type phospholipase A2 receptors in the case of membranous nephropathy. More importantly, let's talk about membranoproliferative glomerulonephritis, okay? This is an important one too, with a classic buzzword associated with it. Tram track. If you hear tram track, think membranoproliferative glomerulonephritis, okay? Membranoproliferative glomerulonephritis, or MPGN, classically shows a thick glomerular basement membrane on H&E that looks like a tram track. To the right here, we can see a very high magnification micrograph of membranoproliferative glomerulonephritis. And note the tram track appearance of membranoproliferative glomerulonephritis is because the immune complex deposition. Immunofluorescence of MPGN shows immune complex deposition. Makes sense. The immune complex deposition of MPGN is classified into two types based on the location of the deposits. It could be type 1, where it's subendothelial, or type 2, if it's dense deposits, right? Type 1 for subendothelial, which is associated with hepatitis B and C, or type 2, dense deposit disease, which is intramembranous and is associated with C3 nephritic factor. Membranoproliferative glomerulonephritis may progress to chronic renal failure. And here we have a cartoon showcasing membranoproliferative glomerulonephritis. We have the renal corpuscle, we have the MPGN that is involving the dense deposits at the intraglomerular mesangium, which actually leads to the splitting of the glomerular basement membrane. And here we can see a pass stain at 100x showcasing features of membranoproliferative glomerulonephritis. Now, what about diabetes? Well, the high serum glucose levels in patients with diabetes mellitus, as we know, causes the vascular basement membrane to be glycosylated non-enzymatically. Yes, sugar is literally sticking to the basement membrane. That can't be good. It's not good at all. This results in hyaline arteriolosclerosis. To the right here, we're seeing some classic findings in patients associated with diabetes mellitus. In regards to glomerular efferent arterioles, they can be affected by diabetes because the glomerular efferent arteriole is more impacted than the afferent arteriole, and this results in increased glomerular filtration pressure. Hyperfiltration injury may result in microalbuminemia and nephrotic syndrome. Diabetes mellitus causes cirrhosis of the mesangium with formation of buzzword Chemistille-Wilson nodules, right? If you hear Chemistille-Wilson nodules, which I guarantee you will, you know that's diabetes mellitus. Diabetes mellitus induced hyaline arteriolosclerosis is treated with ACE inhibitors. Now let's talk about systemic amyloidosis, because it's important. The kidney is actually the organ that is most affected by systemic amyloidosis. Systemic amyloidosis is characterized by deposits in the mesangium, which can cause nephrotic syndrome. And with that, I'd like to congratulate you on your success. You're on the right track. You're completing lecture after lecture. You're reviewing your book. You're retaining the knowledge. You're so smart. You really are. Keep up the good work. Let me know if you have any questions, comments, or concerns. Check the website for updates. And I'll speak to you soon. Till then, take care.